Does Medicare pay for nursing home care? Yes, but only a narrow slice of it, and almost certainly not the part you are worried about. Here is why that matters. The national median for a semi-private nursing home room is now $315 a day. That is $114,000 a year. And most families find out how it gets paid for at the worst possible moment, standing in a hospital hallway. So let me give you the answer straight away. Medicare Part A covers skilled nursing care short-term up to 100 days per benefit period and only after a qualifying hospital stay. It pays nothing at all for long-term custodial care. Custodial care means help with bathing, dressing, eating, and moving around. That is what most people mean when they say nursing home, and Medicare does not cover it. Not for a month, not for a day. That is the short version. The reason it works that way is genuinely strange. The difference between a bill of $0 and a bill of $90,000 can come down to one word. A single word written on your hospital chart by somebody you never met. I will show you which word. I will also show you an appeal right that came out of a lawsuit running more than a decade. It went live last year and almost nobody knows it exists. By the end, you will know exactly what to ask for and when to ask it. Start with what Medicare does cover, because it is real and it is worth having. If you qualify, Part A pays for a stay in a skilled nursing facility for up to 100 days. Days 1 through 20 cost you nothing. Days 21 through 100 cost you $217 a day in 2026. That is up from $209.50 last year. After day 100, Medicare pays nothing. Look closely at that middle number. 80 days at $217 is just over $17,000. People are regularly shocked by that bill because they were told Medicare covers 100 days. It does. It just does not cover all of them in full. That is the first catch. The second one decides whether you get any of those days at all. Everything turns on one word: skilled. Medicare pays for skilled care. That means a registered nurse or a licensed therapist doing something that genuinely requires their training. Wound care after surgery. Intravenous antibiotics. Physical therapy to get you walking again after a broken hip. Custodial care is different. It is help with the ordinary business of being alive. Getting out of bed, getting dressed, getting to the bathroom, eating a meal. It is hard work and it is expensive work. But Medicare's position is that it is not medical, so it is not covered. Here is where people get caught. Somebody will say, my Medicare paid for rehab, so it must cover nursing homes. Both halves of that are true and they are not the same thing. The rehab was skilled, so it was covered. Once you stop improving and the therapy ends, the same bed in the same building becomes custodial care. The coverage stops with it. Nothing about the person changed. Only the label did. For you, that means the question is never really whether mom is in a nursing home. It is what kind of care she is receiving today. Now, the qualifying hospital stay. Before Medicare pays for a single day of skilled nursing, you must have been a hospital inpatient for 3 consecutive days. People call it the 3-day rule or the 3-midnight rule. 2 details trip up almost everybody. It is counted in calendar days and the day you are discharged does not count. So if you go in on Monday and leave on Thursday, you have Monday, Tuesday and Wednesday. 3 days. You qualify. Go in Monday and leave Wednesday and you have 2. You do not. That sounds like paperwork. It is not. It is the difference between a covered stay and a bill you pay yourself. And there is a worse version of this. In that version, you can spend 4 nights in a hospital bed and still have 0 qualifying days. That version is called observation status. Observation is officially an outpatient service. You are in a hospital bed, in a hospital gown, wearing a hospital wristband, treated by hospital staff. On paper, you were never admitted, and observation days do not count toward the 3. So why does it happen? A nurse explained this well in the comments on one of these videos. It is worth repeating because the mechanism is not sinister. Say you arrive with chest pain. If your EKG looks normal and your blood work comes back clean, there is no documented reason to admit you. So you go on observation while they watch. If the blood work turns positive, you get upgraded to inpatient. Most scheduled knee and hip surgery is observation too, because most people go home the next day. The trouble is what happens when you do not go home the next day. You need rehab, you go to a skilled nursing facility, and Medicare looks at your record and sees 0 inpatient days. People in exactly that position have paid up to $30,000 out of their own pocket. Hospitals do have to tell you. If you are on observation for 24 hours, they must give you a form within 36 hours. It is called the MOON, the Medicare Outpatient Observation Notice. A new version of it takes effect in April 2026. But here is the thing about that notice. It tells you. It does not ask you. That is the trap. And until recently, there was nothing you could do about it. Which brings me to the part that almost nobody has heard. A group of Medicare beneficiaries sued over exactly this, and they kept at it for more than a decade. The case is Alexander versus Azar, later known as Barrows versus Becerra. A federal appeals court ruled that a nationwide class of patients can appeal to Medicare when a hospital changes their status. Medicare then wrote it into a final rule. Retrospective appeals opened on the 1st of January 2025. Prospective appeals opened on the 14th of February 2025. They are live right now. Be careful with the boundary, because it is narrower than people hope. This covers you if you were first admitted as an inpatient and the hospital later reclassified you to observation. If you were put on observation from the very beginning, you still have no appeal right. That is an unfinished piece of the law, and I am not going to pretend otherwise. But if you were switched, you can challenge it. That is a real, current, usable right, and it exists because somebody else was stubborn for 14 years. There is one more wrinkle, and for once it is good news. Many Medicare Advantage plans may waive the 3-day rule completely. If you are on an Advantage plan, you might get skilled nursing coverage with no qualifying inpatient stay at all. That is a genuine benefit, and it is worth knowing where your plan stands before you ever need it. Critics do raise a concern, and I will report it as a concern rather than a fact. Some argue that plans use the waiver to move people out of an expensive hospital bed too soon into a cheaper facility, worth asking about, not worth losing sleep over. And from January 2026, Medicare is running a demonstration of its own. It waives the 3-day rule for people having 1 of 5 surgical procedures, and it runs through 2030. The rule is loosening, slowly. So suppose you use all 100 days. What then? The bill becomes yours. That national median again. $315 a day, roughly $9,500 a month, nearly $115,000 a year. Those figures come from the Care Scout Cost of Care survey published this March, built from around 16,000 provider surveys. Very few people can pay that out of income. So most do not, which raises an obvious question. If Medicare is the primary payer for only a small share of nursing home residents, who is paying for everybody else? Medicaid is, and it is not close. Medicaid is the primary payer for 63% of nursing facility residents. Medicare is the primary payer for 14%. In rural facilities, the Medicaid share is 66%. That single statistic is the honest answer to the question in the title. Long-term care in America runs on Medicaid, not on Medicare. The two get confused constantly because they sound almost identical and they are completely different programs. The catch is that Medicaid is designed for people with very limited assets. So for most families, the real question becomes how you get from here to there. That is where the rules get sharp. Medicaid looks back 60 months, 5 years counted from the day you apply. Any gift or below market transfer inside that window can trigger a penalty period where you are simply not eligible. Signing the house over to your daughter to protect it is the most common expensive mistake in this entire area. If you are married, there are real protections, and they are better than most people expect. In 2026, the spouse staying at home can keep somewhere between $32,000 and $162,000 in assets. The exact figure depends on the state. They can also keep a monthly income allowance. It starts at $2,705 and runs up to about $4,066. Those rules have a name: spousal impoverishment protections. They exist for one reason, which is to stop one person's care from bankrupting the other. Ask for them by name. Which leaves the question I see asked more than any other. What happens to the house? Let me be precise here, because the fear is bigger than the fact. Medicaid cannot take your home while you are alive. What exists is a program called estate recovery, and states use it to seek repayment from your estate after you die. While you are living there, the home is generally exempt up to an equity limit. In 2026, that limit sits somewhere between $752,000 and $1.13 million. Each state picks its own figure inside that band. A law signed in July 2025 sets a hard national ceiling of $1 million from 2028. So the honest version is this: the house is usually safe while it is somebody's home. It is the estate afterwards that is exposed. That is a very different problem, and it has a much longer runway. It is the one worth taking to an elder law attorney early rather than late. One last gap, because this one catches people who did everything right. Long-term care insurance is the private answer to all of this, but nearly every policy has an elimination period. That is a stretch of days you pay for yourself before the policy pays anything. 90 days is common. Somebody left a comment about a father who paid $200 a month for 30 years. The policy would not pay because a 90-day requirement had not been met. I do not know the details of that case, and I am not going to guess at them. But the lesson stands on its own. If you own a policy, find the elimination period and read it today while nothing is happening. That number decides whether the policy actually helps you. So what do you do with all of this? 4 things, and none of them cost anything. 1. If you or someone you love is in the hospital, ask out loud every single day: am I an inpatient or am I on observation? Ask a nurse, ask the doctor, ask the case manager. The answer can change without anybody telling you. 2. If you are on observation, ask for the moon notice in writing and keep it. 3. If you were admitted as an inpatient and later switched to observation, you can appeal. Use the word appeal and say you know about the Medicare observation status appeal process. 4. Find your own state's Medicaid figures, and if you are married, ask about spousal impoverishment protections by name. None of that needs a lawyer. All of it is free. And all of it works far better before there is an emergency. That is the whole reason to do it this week instead of the week you need it. Here is the entire thing in one sentence. Medicare pays for short-term skilled recovery, up to 100 days and only after 3 inpatient days. The long-term care almost everybody is actually picturing gets paid for by Medicaid, by your savings, or by a private policy, one you had better read. Knowing that in advance is worth real money, it is also worth something harder to put a price on. You will not have to work it out in a hospital hallway at 11 at night. Tell me one thing in the comments. Has anyone you know been put on observation status without being told what it meant? I read them all, and I would like to know how common this really is.